For this PowerPoint, we're going to discuss anti-inflammatory medications, anti-arthritis medications, inflammation, our signs and symptoms of inflammation, the common ones we think about: pain, swelling, redness, heat, loss of function. As far as treatment goes, we commonly use non-pharmacological treatments. You may have heard of RICE before. That's rest, ice, compression, and elevation. Pharmacological treatments we use NSAIDs commonly. We also may use corticosteroids as well. Salicylates, the most common salicylate that you're going to be in contact with is aspirin. There are others. Bismuth subsalicylate, that's actually just a fancy word for Pepto-Bismol. That is a salicylate as well. And there are definitely others, but the one that we're going to concentrate on right now is aspirin. The way this works is it inhibits synthesis of prostaglandin. I'm not worried about you understanding that process, but what this causes is antipyretic and analgesic effects. And so our indication, pain and fever. But it also, another thing that it does is it helps prevent platelet aggregation, which, of course, will increase potentially bleeding in people, but we want that sometimes for cardioprotective reasons, whether it's for an acute MI, so somebody's having an acute MI, we help to further protect that by keeping the platelets from aggregating and causing further problem. And then we use that to prevent MI or stroke in people that are at high risk, so that, again, we prevent that platelet aggregation, prevent those clots. So aspirin is cardioprotective. Adverse effects are, adverse effects. The most common adverse effect is actually GI distress. It can cause ulcerations if we're taking a lot of it, especially on an empty stomach. So we'll make sure that they understand those risks, and it's best to really take this on or with a little bit of food if possible. Another adverse effect that we commonly associate with aspirin is bleeding. Again, we're causing those platelets not to be able to aggregate as quickly or as easily, so that can increase the risk of bleeding. It can be nephrotoxic, especially at high levels. And then in children less than 20, we got to worry about Reye syndrome or Rye syndrome, however you want to pronounce that, which occurs when you take a salicylate, especially in children, when they take a salicylate with some viral infections. The problem is a lot of times you don't know if the fever is being caused by virus. So it's best to really just avoid in children less than 20. It can be serious. It's very rare, but it can be serious. It causes swelling in the brain and liver, and can even cause death potentially. So again, very rare, but we want to avoid that. So let's just avoid giving this to kids less than 20 without explicit, orders from a doctor, and we have good reason to do so. Our contraindications, again, people less than 20, especially if they have a viral illness, but a lot of times you don't know, so just avoid that. And then be really careful in people that have the coagulation or bleeding disorders. If they already have those types of disorders where they're not coagulating and easily bleed, obviously an aspirin wouldn't be the best thing for them. Be careful in people that already have kidney problems or kidney malfunction, chronic alcohol use, or any sort of history of GI bleeding. As far as surgery is concerned, we're going to be really careful in surgery. We need to know, so if we're planning to get our patient ready for surgery, we need to know when to stop the aspirin, and when they plan on giving them or starting them back on aspirin afterwards. So just keep that in mind with surgery. Anytime you have a patient that's going for surgery or you're going to prepare them for surgery from the clinic, if they're on aspirin, we always need to assess that. When does it need to be stopped, and when should we start it back up? Interactions, it can interact, of course, with other anticoagulants and increase the potential for further anticoagulation. That's not to say you won't see people taking it. People often take warfarin and aspirin at the same time. Just remember back to when we talked about the cascade and the different levels. So some people need that, but all that means is we're going to know that if we see somebody on aspirin and warfarin or aspirin and heparin or whatever, we need to just watch them even closer for that bleeding potential. Can also interact with corticosteroids and alcohol. Remember, salicylates, especially aspirin, can be tough on the GI mucosa, can cause ulceration, just like alcohol and corticosteroids can do as well. So patient teaching for aspirin, again, no kids less than 20. If you work in pediatrics, you'll always want to make sure you have really good rationale and the doctor is signed off on it and you've questioned it and you've got all the documentation. But for the most part, try to avoid it, especially for fever or following vaccinations, because of that risk for Reye syndrome. It's signs and symptoms of bleeding. We're going to teach them about that, tarry stools, or even red stools, just depends on where that's at. Weakness, pallor, all those signs and symptoms of bleeding, easy bruising. Then we'll tell them they need to make sure that anytime they're going to have a procedure, they notify the provider that they're on aspirin. So if they're going to have dental work done or any sort of surgery or anything, any sort of procedure that's invasive that could potentially cause bleeding, they need to let the prescriber or the physician, whoever's doing that procedure, know and see what they want them to do. If they want them to hold the aspirin, when they want them to start it back up, all of that. Take with food commonly because of that GI upset. And another thing we need to worry about with aspirin is it is available in other combination medicines. So if they're taking it often, there's potential there that they could get too much because maybe some of the other combination over-the-counter medications, like the most common one that I think of is Excedrin migraine or anti-migraine medicines, a lot of times have aspirin, and there's others as well. It's not as common as some of the other pain relievers, but it is sometimes found in over-the-counter combination meds. So they just need to know to read their labels, always read and see if it's got aspirin in it, and then to contact their physician if they have questions. All right, so NSAIDs. NSAIDs are really pretty similar to aspirin. In fact, aspirin can be classified as an NSAID. However, I will really want to separate them because, well, you'll see here in a minute. There's some definite big differences between aspirin and some of the traditional NSAIDs that we think of, such as ibuprofen or naproxen. Those are the over-the-counter NSAIDs. You also have the prescribed NSAIDs, such as ketorolac and diclofenac. There's others as well. Let's talk primarily about those over-the-counter because those are the most common ones you're going to see, ibuprofen and naproxen. However, you will still see plenty of ketorolac, plenty of diclofenac out there as well, especially in the hospital or in the medical setting. The way this works, it works on your COX-1 and COX-2, leads to anti-inflammatory and analgesic effects. Don't worry so much about, again, this direct action as far as the COX-1, COX-2. Just understand more that it's got anti-inflammatory and analgesic effects. And so those are indications: pain, mild to moderate pain, and fever. Pain associated with arthritis, pain associated with inflammation, pain associated with all kinds of stuff. Those are primary indications. Adverse effects, again, it's really similar to aspirin in the fact that GI distress is probably the most common adverse effect, potentially GI bleeding. Again, we can have some ulceration. So a lot of times it is good to take this with a little bit of food. Also renal dysfunction, especially with certain levels. These can cause a little bit of edema. And then one major way that the traditional NSAIDs, or just NSAIDs in general, differ from aspirin, and why I like to separate these two, is these are cardioaverse. these cause potential bleeding and they potentially can thin the blood, but the research shows these actually can increase the risk of MI and CVA, whereas aspirins traditionally are thought of to decrease the risk. So we use those a lot of times as cardioprotective. NSAIDs are cardioaverse. They increase the risk of MI or CVA. So I want to make sure you make that distinction. Aspirin, cardioprotective, decreases those risks. NSAIDs such as, the traditional NSAIDs, aspirin, ibuprofen, traditional NSAIDs, ibuprofen, and naproxen, and then the ketorolac or Toradol, diclofenac or Vytorin, those increase the risk of MI or CVA. Okay, so aspirin, cardioprotective, NSAIDs, cardioaverse. I think I may have beat that horse a little bit, but that's okay. I just truly make sure you understand that. Aspirin, cardioprotective, NSAIDs, cardioaverse. Contraindications, again, bleeding, active GI ulcerations. Those we wouldn't want to give an NSAID for. We'd want to be really careful in people with a history of GI bleeding, people with a history of renal dysfunction, or if they have renal dysfunction now, what level is that? Interactions can interact with anticoagulants just like steroids, just like aspirin. Anticoagulants like aspirins or corticosteroids like aspirins, alcohol. These can also interact sometimes with antihypertensives. We learned about that with our ACE inhibitors and diuretics. Our patient teaching: avoid alcohol, know the signs and symptoms of bleeding, just like we talked about with aspirin. Take with food for GI upset. Notify provider for procedures if you're taking these, consistently. They need to give you some instructions on what to do with that. And then if you are anytime you're sending somebody home with a prescription NSAID, let's say you're sending them home with ketorolac or what have you, Vytorin, you will make sure that they understand they shouldn't take over-the-counter NSAIDs with that. So they'll need to call their doctor, for any more further advice on that. And then, of course, notify provider of before procedures. I think I already mentioned that, but just really want to hit that one. All right, acetaminophen. Acetaminophen is very common medicine. You've probably taken it. I'm sure every single person that's listening to this has taken it multiple times. This is the med that mom always went to whenever we had pain or a fever. It can't be given IV. Back in the day, this was a big deal. They would always state. I remember, and probably half, if not more, of the nursing classes I took, they were just adamant. Acetaminophen cannot be given IV, but now it can. So yes, we do give acetaminophen IV. Obviously, it's got to be the IV preparation. It's not like you can just crush some up, throw it in their bag of normal saline and go to town. It has to be the IV preparation. It's called Amsura or something like that. I've never actually hung it, but I've taken the in-service about a dozen times. This guy used to come to the ER literally every month and try to sell us on it. So he would always bring lunch. So I went every single time. I was like, oh yeah, no, this is great. I bet it's amazing. But the ER only used one dose that entire year that he came every month, because I think there's still some of that stigma with it. But surgery uses it a lot, and it has been shown to reduce the dependency on post-surgical narcotics, which is awesome. They use it a lot in surgery. I've heard of it in labor and delivery, and I'm sure there's ERs out there that use it appropriately. I know the ER I worked at was just a little, for whatever reason, and docs are all different. So the docs and the NPs and all that, they just really it never took off. They have other meds that they rely on, so they just went with those. But the one time that we did use it, it seemed to work. It's a gram usually, that you give IV pretty quickly. It's like 15 minutes. But the same rules apply. They still can't have any more than 4 grams in a 24-hour period, so we would want to make sure they understood that, especially for sending them home. And then we would want to make sure we take that into consideration anytime we're giving them anything with acetaminophen. The action, here's the thing, as far as the pain goes, because our indications, of course, are pain and fever. But as far as pain is concerned, we don't really understand. We think it works on the prostaglandins, and we believe we have an idea of what it's doing. But if you read different research articles about it, they'll all kind of have their own little take on it, and they'll all at the end of them say, but we don't really know. This is what we think, but we're not 100% sure. As far as the fever goes, we do know how that works. It works in the thermoregulatory cells of the hypothalamus. It causes sweating and vasodilation. But as far as pain, we're not 100% sure of the analgesic effect, like how it accomplishes that. Our adverse effects, the classic adverse effect we think of with acetaminophen, of course, is hepatotoxicity. So our contraindication, of course, would be liver disease. We'd be careful in anybody with any history of liver disease or liver impairment. We'd also be careful in people with chronic alcohol use because of that potential for liver impairment. Interacts, of course, alcohol, and also warfarin, because again, warfarin's more kind of a liver disease, a liver medication. It affects those liver clotting factors, right? So we would be careful with that. Patient teaching with acetaminophen. It's very important to do appropriate patient teaching. The reason why is because everyone is familiar with acetaminophen, but they don't really know a lot about it. They know some, but once you get out there and you start talking to people about it, you'll realize it's not good information so much that they understand. Because, again, mom gave this to you, and mom gave this to that person's mom. Everyone's mom gave this to them. Moms, for whatever reason, love acetaminophen. And I get it, because it works real well. I've used it for my kids a lot. It does work. It's good fever reducer. It's good at mild pain. And it's fairly safe if you use it appropriately, but it's not completely safe. And you got to think of some things, and we've got to make sure we're educating people about that. So first and foremost, for adults, no more than 4 grams in a 24-hour period. And in all honesty, that's a lot too. They shouldn't be taking 4 grams every day for a long period of time. It's just for a short period of time that it's safe to take 4 grams. There's a lot of hospital systems out there that are moving more towards a 3 gram a day Tylenol or acetaminophen, same thing. The the FDA still recommends no more than 4 grams, so fine, that's what we go by. But there's some systems out there that are saying no, we're not going to give them any more than 3 grams in a 24-hour period. So you'll just make sure you know what the protocol is for the place that you are employed, and know that federally the federal recommendations are no more than 4 grams in a 24-hour period. And of course, in children, it's weight-based at that point. It's 15 to 20 milligrams per 10 to 15 10 to 15 milligrams per kilogram per dose. When you get to peds, you'll get more into that. We're not going to do that in this class. We're going to concentrate on adult for acetaminophen as far as that's concerned, and your adult dosage is 4 grams. Avoid taking with alcohol. We're going to educate them on that. And we're going to educate them just like we did with aspirin and with NSAIDs. I don't believe I mentioned that, but I need to bring that up here. Always read the labels of your over-the-counter medications, because those combination medicines, you will see ibuprofen in those or naproxen in those sometimes, but acetaminophen, it's in everything, man. It is in everything. If it's a combination med, it almost always has acetaminophen in it. And you can see how someone could easily get overdosed with acetaminophen. If they go home with Percocets, let's say, or Norcos, right? Those has a narcotic, whether it's oxycodone or hydrocodone, and then a certain amount of acetaminophen. It used to they could have up to 500 milligrams per pill. Thankfully, now they've reduced that to 325. But if they're taking 2, that's 650 milligrams of Tylenol or acetaminophen every time they take it. And if they're taking that every 4 to 6 hours, I mean, they're almost already at their max, right? So, and then if they get, let's say that they have trouble sleeping, so they take Tylenol PM for that. They don't even think anything of it. That Tylenol PM is going to have Tylenol in it, but it totally does. Or, there's maybe they get they get a little under the weather and they think, oh, I need some NyQuil or whatever, Dayquil. All that stuff's got acetaminophen in it. And people unintentionally overdose on acetaminophen quite a bit. Again, mom gave it to you as a kid, so it's got to be safe. And you can go, anybody can walk in and buy a bottle of it, 500 milligram tablets. And so it's got to be safe. That's what they think. But we know it's not necessarily safe. It's definitely not safe at high doses. If someone does become or does get overdosed, they have to seek medical help immediately. You've only got so many hours before the body or before the liver starts to become affected. What happens with acetaminophen is when it's broken down in the body, there's a certain enzyme that's left, and it affects the liver. Your body can get rid of that up to a certain point, and right now our recommendation is 4 grams. Right, anything over that, the body has a tough time controlling it, and the byproducts of that acetaminophen can attack the liver and do damage. When people get a very high level of acetaminophen in them, the body cannot handle it at all, and the liver damage can be significant. So if a child, downs the whole bottle of grape acetaminophen, they need to seek help as soon as possible. There is a medicine that we can use called acetylcysteine, and we talked about that with respiratory. It can protect the liver through an acetaminophen overdose, but it's all dependent on timing. If you can get there within 12 hours, that's best. Within 24 hours, they can, from what I've understood of the reading and from what I've understood in my own practice, they can usually get you through that. I need more than that, and the damage is a lot of times done. The problem, of course, is acetaminophen overdose. You don't know for days. It takes 48 hours, 72 hours sometimes to really start seeing the effects. The person might start feeling icky, but then you're like, oh, they're under the weather a little bit. But when you start noticing their yellow tone to their body, and their eyes and the sclera, all that, and then notice that they're vomiting a lot and they just are really sick, by that time it's too late. And unfortunately, sometimes that's when people will come in, and then you'll do a full med reconciliation, go, oh my God, you've been taking way too much acetaminophen, or it was an intentional thing, and I've unfortunately seen that as well. So it's not safe. They need to understand it's of course it's safe in the prescribed doses, but it can turn deadly, and they need to understand the how to avoid that and what to look for and all that. So we want to really educate people on acetaminophen when we're sending them home with it, and we are sending them home sometimes with a prescription for acetaminophen, especially in kids with high fevers. They'll send them home with a prescription for acetaminophen. We need to make sure they understand exactly how much to give, exactly the type of acetaminophen. Back in the day, you used to be able to get a couple different types of acetaminophen. Luckily now they're all the same strength, thank God, because people did die. Children did die because the strengths were different. But thankfully now they're the same, to my best understanding. But we always want to make sure that they understand. Look, this is, it's 125 milligrams per 5 milliliters. Make sure you check your bottle. Maybe, because believe me, people will keep meds forever. I mean, my mother has meds from decades ago. I guarantee it. Because when I was a kid, she had them from like the 70s, 60s. And I mean, I'm sure those meds are probably still in there as well. But anyways, they need to understand it's the 125 per 5 milliliters, what we usually use, and exactly how much to draw up and how to draw it up. It says a teaspoon. You don't pull out a teaspoon because maybe your teaspoon's not correct. You give them a syringe, or you give them the medical teaspoon that they need to use, and how much of that to give, and exactly how to give it, and exactly when to give it, and how much not to give. We will make sure that they're very well educated, because unfortunately there are horror stories out there of parents unintentionally overdosing their child, and they didn't realize that they had done it until it was too late. Because again, they don't really start notice or showing those big symptoms until 48 to 72 hours later, and that we all know 24 hours is like the max, right? 12 hours is the best time to get in if before then, but 24 hours is the max. Anything after that, we know the damage is done. So just please, please, please appropriately educate your patients. DMARDs, common DMARDs are methotrexate and etanercept. There's others as well for sure, but those are the ones that I've seen most commonly. A lot of times they're given sub-Q. The methotrexate can be given PO. The way these work, they all have kind of their own little mechanism of action. Just understand that they work to slow the degeneration and progression of rheumatoid arthritis. That's really what you need to know about the action, and that's their indication for the most part, autoimmune disorders, so rheumatoid arthritis. But you will also see them used for psoriasis, eczema, lupus, all kinds of things. DMARDs are used for as far as autoimmune diseases go. So if they're used for autoimmune diseases, you can imagine the adverse effect is immunosuppression. Also can cause some liver damage and bone marrow suppression. Contraindicated, of course, an active infection. If you're immunosuppressed, that active infection can become worse. So we would certainly not want to give it to anybody with an active infection. Be careful in people that already have bone marrow suppression and can interact with other immunosuppressant drugs like corticosteroids. Patient teaching with DMARDs, it can take several months to have an effect. It's not like they're going to go home, take the pill, and immediately feel better. It takes a while for that to really start having the effect on your, whatever it is that you're taking for your eczema, your rheumatoid arthritis, or whatnot. They will need follow-up lab tests. We'll need to have them report signs of bleeding, signs of infection. It's a big deal. Make sure that they understand the signs of infection and what to look out for. And to report those to their doctor. And then, of course, avoid live vaccines. So anytime they're going to go for a vaccine, they need to let the prescriber know, look, I'm on a DMARD. Is this vaccine safe? Muscle relaxers. For this chapter, we're primarily going to talk about skeletal muscle relaxers. There are others as well, but we're going to primarily talk about skeletal, and I'll get into that a little bit here in a second. So let's talk about these abnormalities, muscle spasm, muscle spasticity, and what's the difference. Spasm is that violent, involuntary muscle contraction. It's painful, often results from injury to the musculoskeletal system. Again, injury to the musculoskeletal system, whether it was you were in a car crash and you tensed up and the jarring of the crash caused injury to the muscles, or you break a bone, that can cause muscle spasms. As opposed to spasticity, that is a result of CNS damage, so the central nervous system damage, and that's damage. It causes an excessive muscle response and activity. That can be due to direct injury, so they'll be due to multiple sclerosis, cerebral palsy, a stroke. So it could be like direct mechanical damage, like I said, with brain or spinal cord injury from a motor vehicle accident, or falling great distance or whatever. It could also be due to internal conditions that cause the damage, such as multiple sclerosis, stroke, cerebral palsy, things like that. Non-pharmacological treatment. Rest is important, to rest that area. Heat is good, right? As opposed to cold, we want heat for the muscle relaxer. Positioning and physical therapy. Pharmacological, we use muscle relaxers. We're going to talk again about skeletal muscle relaxers, or the traditional centrally acting skeletal muscle relaxers. I will say you will also see anti-anxiety medicines. The benzodiazepines are used a lot of times for muscle spasms as well, especially in acute situations, but sometimes even for chronic, but especially in an acute situation, they're going to go to the benzo first because it helps cause relaxation a little quicker. So our centrally acting skeletal muscle relaxers, cyclobenzaprine, tizanidine, baclofen, those are the common ones. There's others for sure. You will see baclofen and cyclobenzaprine quite often. The way they work is in the CNS. They interfere with that reflex that's causing the muscle spasm and to help relax that muscle. And so that's our indication: spasm and spasticity. Our adverse effects, well, they're centrally acting. They act on the central nervous system, so that already tells us our adverse effects: dizziness, drowsiness, confusion. It can also cause a little GI distress, and these can cause dependency, so we'll keep an eye on that. It's contraindicated in an acute MI, so an acute MI we would not want to give it because these can actually cause some QT prolongation, and we certainly wouldn't want to do that in an acute MI. Be careful with seizures because it can sometimes mess with the seizure threshold. Be careful in people with cardiovascular disease. Can interact with other CNS depressants. So we know that, right? We wouldn't want to take this with alcohol. We wouldn't want to take this with other CNS depressants without, strict observation by the doctor. Patient teaching may have a sedative effect, and we're definitely going to teach them about that. So that means don't use heavy machinery. Don't do anything that needs your full concentration while you're taking these. Of course, avoid alcohol. And because of that GI upset, we're going to tell them to take these with food.